Hi everyone, I'm Rowena, and I'm a pediatric neuropsychologist over at Kenny Krieger Institute and also at Johns Hopkins University. I collaborate closely with Dr. Farner and Dr. Harris across many of the patients we see. So today I'm going to be talking about the kind of clinical utility with neuropsych testing in KAT6A syndrome and more broadly in genetic neurodevelopmental disorders. So I'm just going to be reviewing over the purpose, the benefits of a neuropsych assessment, talking about some common referral questions we get more broadly, what's involved in the testing, and then why do we think it's important specifically for more genetic disorders. So what is a neuropsychological assessment? There's a wide variety of different types of testing, and you might have experienced many of these already. There's psychological testing, educational testing, speech, occupational, physical, and then there's what we call as neuropsych testing. Clinical neuropsychology is really kind of a specific field within clinical psychology broadly, where it's specifically to understand relationships between brain and behavior, and how these relationships helps with diagnosis of brain disorders or neurological disorders, assessing in terms of like cognitive and behavioral functioning, and also helping with more of the treatment planning. Sure. And so you might actually see like some of the tests that neuropsychologists use have some overlap with many of these different areas in terms of including psychological, educational, or academic testing, speech, like language measures. But it's really the difference is integration. So we use a lot of different, more kind of variety of measures, and the way we integrate those to kind of think about informing us how we think the brain systems are working. Within neuropsychology, there are many different types. There are screeners or consultations, basically to kind of see if whether or not we think neuropsych testing is appropriate at this time. Focused assessments where you have very specific questions. For example, is this attention difficulties? Are we ruling out ADHD or anything like that? There's forensic evaluations for more legal contexts like traumatic brain injuries and whether or not that's causing or what we think might be causing some of the changes in function. And more so in these bolded text are what we see with a lot of patients with genetic syndrome is for diagnostic purposes, progress evaluations, rehabilitation or treatment, and for clinical research. Diagnostic assessments oftentimes for us to look at more broadly neuropsych or cognitive functioning overall, and using those to inform us whether or not are more psychological conditions going on in addition to neurological conditions going on. Progress evaluations are assessments in respect to any kind of interventions that you've been receiving and to really kind of mark progress as you're going. So I describe it as if like you're getting height and weight measurements. The more data you get, the more we can start building a curve and getting a sense of what your child specifically looks like developmentally over time. And so progress evaluations over time helps us kind of build that curve and understand your child more specifically better. Rehabilitation and treatment are in the context of any kind of, like for example, head injuries and treatments in relation to that and seeing how we're responding to that. And then more broadly, clinical research. So thinking about how can what we know about cognitive functioning broadly and also specifically your child would be building to help what we think as treatment for therapies specific for that population. Well, neuropsychologists can, again, use different measures with other assessments. Again, neuropsychologists, the testing is more specifically about differences in brain, inferences about brain functioning. So we mostly kind of differ in terms of how we're making inferential considerations about brain functioning. The assessment that we do sometimes can actually provide a little subtle cues about dysfunction in the brain before we might be actually able to see some structural anomalies more broadly. So for example, if you have fluid in the brain like hydrocephalus, sometimes you might start to see a little bit differences in cognition before you might have physical manifestations of it first. And so it helps us to also kind of signal in conjunction with neuropsychologist or neurologist on kind of what's next steps for kind of the workup you might need. And we also look at your performance relative to other children, same age, but also more specifically to yourself. So we look at more of a generalized kind of group, but also looking at more individual kind of development as well. There are many domains assessed in neurocognitive development testing, and actually neuropsychologists also do some developmental testing. So there's that question of like when we do cognitive testing, sometimes if you see a neuropsychologist, they might start to do developmental testing if we feel like that might be more appropriate at that point, and then decide to move on to cognitive testing as we think that it might be more helpful. But many domains are assessed, including intellectual, language, visual processing or nonverbal reasoning, motor skills, attention, executive functioning, or how we plan, organize, inhibit behaviors, memory and learning. Sometimes we do academic skills, although that's not as common in medical settings. We also do a lot in terms of more social cognition, in terms of how we process social cues. And we also assess for kind of more like general emotion, behavioral functioning, and adaptive functioning. So how you're able to kind of use these skills in more day-to-day context in society. The common referral types we get with the neuropsych assessments is if there's any kind of persisting problems or a new kind of cognitive concern. So this might include persistent kind of slower develop or perceived slower development, so developmental delays. If there seems to be a decline in kind of thinking skills after an injury, so it could be seizures, could be virus or viral infections, head injuries. Regression, which is kind of like a loss of skills, so meaning that you might have seen some gains and suddenly it seems like your child not displaying those skills anymore. Cognitive complaints in the context of more psychiatric like illness, so if we're thinking about like anxiety, mood, and then attention, learning disability, and also rule out of autism disorder. Those are very common questions we get. More so, we oftentimes in clinical settings or medical settings, we're used for more patient care and access to services. So looking at the neuropsych testing to better understand what are your specific strengths and weaknesses for your child, and looking at what kind of dosage of interventions would be most helpful for your child. And then with the diagnosis, sometimes helping open access to services. We look at cognitive functions in relation to new medical diagnosis and treatment. So thinking about, for example, seizures, for seizure medications or surgical interventions. So how are you making progress or cognitive development in relation to the medications or different types of treatment you're receiving? In addition to more of the behavioral types of interventions. And last is transition planning. So for your child who's going from like adolescence towards adulthood, we think about are they able to kind of comprehend complex decision making, like medical decision making, financial decision making, and then looking at that in relation to cognitive skills, we help families kind of navigate questions about things like guardianship, power of attorney, different or alternatives, and then things of questions about like families might have about like residential living, things like that, or vocational. Neuropsych testing usually incorporates several features. One is using norm reference measures, which means standardized test. And so sometimes you guys might have seen, like if with neuropsych testing, you might have seen one of the more common ones is kind of like Wechsler's test, and always like the people remember those red and white blocks, but like the norm reference measures are to look at your child's performance in relation to the children with similar age in the large population. But more importantly, sometimes for children with genetic conditions, because we know they develop in a different rate than children without the condition, we often look at more qualitatively too, in terms of like what are specific skills that are developing specifically different in your child, and looking at that more individually. So not just group level again, but more individually for your child as well. We also interview a lot of kind of family members, so usually parents, but sometimes with school or therapists as well, to get more information about progress. And then we also look at behavioral observations. So things like fatigue, motivation, how your child's feeling that day, compliance, any kind of sensory or physical impairments like hearing or vision loss, medication, sleep, and more. Because again, testing, I describe it as a snapshot of a child's functioning in one day. It's like kind of like, and I describe it as if like if you were to get if a prick for blood glucose, right? If the day of what you eat that day, sleep, functioning that day, all those might impact that outcome, so and metric. And so like similarly with our scores, we always look at it in relation to the context of how your child was doing during testing environment and in response to behavioral management strategies with the examiner. So someone who might have more experience working with your children with the condition versus someone who doesn't. And then we also might have recruit information from school and home, or observe your child in school and home to look at these skills across settings. And the reason that this is important is that, when we think about child's scores, right? It's really not so informative unless we know like the context of how they're making that kind of score. And so, for example, we oftentimes for one of the common visual kind of motor tests or constructional tasks, we'll have them use blocks to make that design up there. And all three options on the bottom are incorrect in some ways, but they tell us different information of why you have that result. And so, for example, the first one might be someone who's inattentive, who missed something, didn't kind of self-correct. And then second one might be someone who have a particular focus. So they tend to focus on parts of your design. And that might indicate, again, different parts of the brain that's being affected versus the first one. And then third is just if a child who can't behaviorally regulate for testing and they just refuse to test. So all of those would score the same way, but they all inform us different what's underpinning and what's might be going on for a child. And so that's why, a lot of we kind of integrate a lot of material when doing these assessments to help us best inform what these scores mean. And then we might, if when testing, you guys might get requests for lots of different records. We often ask for medical records to understand the context of their medical history, developmental history. We might ask more specifically also from the referring provider, so like physician, on what their concerns were in addition to parents' concerns. Background questionnaires about your child's earlier development, any past evaluations to help us get clues about how they would have been progressing so far. Informant questionnaires like teachers, other people who might interact more regularly with your child, and again, some informal samples of like schoolwork, things like that, which again, because sometimes children might respond differently in a kind of more standardized kind of testing than in a more naturalistic setting. So again, these might be helpful for us to kind of better understand test results in context of the big picture. Okay. And I'm not going to go too much in detail about like score interpretation, but it's always a little confusing because we use so many different things that are essentially is representing the same bell curve. So this bell curve is basically representing about how the child or the person who's testing performing in relation to your comparison group. Generally, I always tell families most helpful is usually the percentile rank for me because it tells me a little bit more about where a child's performing in relation to the group. For example, out of 100 people, where a child is performing in order. So if you're like on the 27th percentile, you're performing above 27th people in that group from like in order. So ordering the performance scores. But this is generally to compare this with other people in regards to with same age or demographics. But typically, I find it more helpful for kids with medical conditions or more complex medical conditions is also to look at you more individually. So kind of, again, marking and kind of thinking about your scores each time you're testing over time to look at that curve. Because, specifically for genetic neurodevelopmental disorders, what we do know is that a lot across different disorders, they have a very specific kind of areas of strengths and weaknesses. And as Dr. Harris had mentioned, I think oftentimes for KAT6A, like we typically notice the language as being more effective because that's more prominent in earlier development than other cognitive skills. But while we are kind of looking at, for neuropsych testing, what we would do want to do is kind of look at more broadly across cognitive functions, and then also marking each of those cognitive functions as they're progressing as well, because that typically what we see is that we see that each of these functions they're usually growing, meaning that they're still making progress, but each of those might just be developing at a different rate. And that different rates, the different curves, help us better understand in terms of more individually for your child, what are kind of interventions and how much interventions we would recommend. Because we know there's always a balance of putting your child to have too many interventions where it's not very helpful and it becomes overwhelming, but also earlier intervention to make sure that your child is getting the best out of it and that you're kind of getting a head start in making that curve. But when we think about different curves, there's kind of like the delays, which is basically you're still making curves, but maybe just not as steep. And then stagnation is usually when we're seeing that you're making a curve, but you're starting to make less gains over time. So when you're doing repeat testing, the increment might be a little bit smaller and smaller. And then regression is that we're seeing if we see your scores are starting to dip, so that it's actually your next testing might be a little bit lower than previous testing. And so these are all kind of gives us little signals of what potentially might be going on for our brain systems that are developing. And in relation to kind of more clinical research, neuropsych testing is really kind of important for kind of the earlier steps of thinking about clinical trial development. In order for when you think about clinical trials, or therapies, we need to know what are good metrics for outcomes. And so like, in order for us to even have first step for that, we need to have a better understanding of the condition, and then start to narrow down when we see that there are certain trends, right? And that so that we can think about that as potential markers of what we would expect potentially change when we're thinking of clinical trial usage. And in relation to what Dr. Harrison mentioned, we know a little bit more, and there's a lot of research here who are going to be doing more on language and kind of more communication skill development. But what we do not know much is about that nonverbal skill development. But it seems like that there are a little bit bigger variability in terms of the performance in that for a lot of children we see with KAT6A, and we're not exactly sure why. And so but that does impact when we think about whether a child can do developmental versus cognitive testing. And so today, those two questions are kind of where we're looking at too, is that, at what age are we seeing these cognitive measures where we're thinking about more reasoning tests is more helpful for a child? Sometimes we recommend at like around 5-6 years old, like Dr. Harris mentioned. But what we do know is that, language impacts how we administer some of the cognitive testing in some ways. And so that might be slightly pushed back a little bit later if we think that it's not necessarily you're not getting best benefit from those tests. The other areas that we're also interested in looking at today is more on the social processing, so social skills development. As Dr. Harris had mentioned, there is general compared to the overall population, there is a little bit slightly higher representation of autism spectrum disorder in KAT6A, but that's also said in general language impairment. So like thinking about those without KAT6A and having language delays or significant more speech language impairment. And so, what we're also interested in is kind of looking at more of this kind of presentation with individuals with KAT6A and autism and without autism, because what we do see is that even those who are diagnosed with autism tend to present differently than those with autism without KAT6A syndrome. So, if you have any questions, I'm happy to answer your questions, or you can also send me an email if you have any questions after the fact.
Thank you. One question. If over time families are getting multiple assessments as their children get older, would you say it's more important to repeat the exact same test panel to get changes over time, or should you continue to look for the next best, newer test panel, if you will, right? Because I know my daughter had one type of test years ago. We're going to do one with you that will be a different panel of tests. They'll presumably say different things because they're different tests. I mean, so what's more important? Should we stick with the same panel and just do that repeatedly, or should we continue to evolve and do different tests every time?
Yeah, I would say oftentimes baseline testing, you'll see potentially a difference between the first test. Baseline was always kind of what we describe as the first evaluation with the follow-up evaluation, because the first one is we're trying to get a feel of what is the best battery for your child, right? And so like what you mentioned earlier, someone testing might give a traditional kind of like a cognitive battery, and they recognize like, hey, this is probably not best captures all these subtle strengths and weaknesses for your child. And the next repeat testing, they might change that battery because they feel that there's a better test that are able to capture those skills, particularly for individuals who might have a little bit more language difficulties. I think when I see like children, I typically, when I feel like that the test is not best capturing those skills, there's no point in repeating those then, because we know that they're not a good metric for your child then. And so then I would change it and then start to continue using that new metric instead.
Thank you very much. Doctor, do you have experience with the Glenn-Doman method?
Oh, sorry?
With the Glenn-Doman method. It's kind of like a program that can potential some brain functions. Yeah, human potential. Glenn-Doman.
I'm not familiar or haven't heard of that. Is it more for cognitive kind of interventions, or? I'll be happy to talk to you a little bit more about that separately. If there are different variety of cognitive interventions are now have been kind of in the mix for different kind of medical populations, and some have been more empirically supported and some haven't. So yeah, I'll be happy to talk to you about that separately.
I have a depression something usually seen at KAT6A?
Dr. Harris, you might want to talk a little bit more.
Yeah, so typically, no, actually. I mean, it certainly the rates of depression and anxiety are higher in all children with intellectual disability and developmental delay than other populations because their life is more difficult, right? The world is not designed for them. The world is designed for typically developing children. And so certainly that's the case. However, actually, again, in KAT6A specifically, we see remarkably low rates of these sorts of, or at least the manifestations of it. It's always a little bit challenging in a kid who cannot tell you how they're feeling to know that, but we don't see higher, proportions than compared to some other genetic intellectual disability syndrome, which actually see lower.
Sorry, I forgot it.
I just wondered if you had a frequency for some of the testing, because like schools, when they're looking at it from their perspective, they don't really want to test that often. But what would a recommendation be from a KAT6A
Yeah.
standpoint?
So usually like schools, and it might be a little bit varies for across district, but they usually do testing about every 2-3 years. I would recommend about every 1.5 to 2 years for testing, just because again, like, there's just like there's more medical complexities with like the syndrome. And so we want to make sure that, like we're tracking cognition in relation to all these things that you're really kind of managing at the same time, right? And so we typically will have we recommend a little shorter intervals. We do have some overlapping measures with school testing in some ways, so they might do some cognitive testing, but again, with neuropsych testing, you get a little bit broader, and you have a lot more kind of cognitive function tests being assessed than school testing.
So when you guys are doing some of your testing, so Izzy just had a autism screen done.
Mm-hmm.
And I know that we have a good percentage of kids that are being diagnosed with autism. I also know that originally it said autistic-like tendencies, which I always felt described my daughter. But within that screen, she had a lot of areas that were really high and then some that were next to nothing. Is this typical of something you guys are seeing?
And that's exactly why we're doing the study today, right? Like we are seeing that it seems like that from a qualitative standpoint, we see that there's that diagnosis, but even with the diagnosis, the presentation is just slightly different with what we would expect for someone with autism without the genetic syndrome. And so, I think our kind of questions are looking at this is kind of thinking about whether or not there's different ways of potentially kind of the social cognition, social processing that's different in KAT6A than others with with autism without KAT6A too.
I just wanted to share something. Our son is 37 years old, so testing when he was in school when he was young was very different. But when he was 14, we had a really good psychologist. And everything that was done with his population was pick symbols at that time, pick symbols. So they were doing his testing, nonverbal, poor fine motor skills. He was bottoming out. And then she just had this idea, and she's going to bring out actual photographs. Well, he could not identify any pick symbol. He identified every photograph exactly. So we all of a sudden knew his receptive language was much higher than he could demonstrate. And that kind of changed everything for us. So just sharing, that was a long time ago.
If we have recent neuropsychs that we did privately, is it still beneficial to your research to have our daughter get tested by you?
Yes, absolutely. Even if you've done testing recently, we still love for her to participate. Just because they might have done different things, and there's a large battery of potential tests you can use for neuropsych testing. It's really just kind of picking ones that are best catered to your child to be helpful, basically.
And we worked with a person to do that, but when we did our testing, typically it would take a person one day. We did it over we had 5 or 6 visits.
Right.
To get through the testing. So how is it that you're doing it in an hour and a half? Right.
So we're doing only very truncated, right? We're looking at very focused questions. So today, we're particularly interested in more nonverbal skills. And so you may not see as much more language assessments or verbal assessments with us today. And so we're trying to kind of pick a small battery so that we're kind of making it easier for a lot of families who are out of state to be able to participate, but also looking at areas that might not have been as researched more heavily, and so that we can start to get a little bit more clues on what's going on.
also really important for us to note that what we are doing today, while Dr. Eng is so kind as to, give families as much reports as possible because we want to help you and your children in schooling and things like that, that what we are doing today is research-based testing. So we are really focused on a very narrow part to try and figure out the next steps for research, okay? So this is nowhere near a complete battery that you would get
Right.
in a clinical setting. This is research testing.
Thank you.
Of course.
Any other questions? Okay, thanks, Dr. Eng.